Hello, everyone. My name is Mayumi from Hiroshima, Japan. So thank you for that nice introduction and also the opportunity to present today's topic. So shall we start? So I think when we talk about healthcare system resilience, that the resilience is that continuous process. And I put the little figure when you think about, I think everyone is kind of familiar how disaster phase cycle and how this concept of resilience fit into. So once, events occurred and in this context for us, it's disasters. And, that the damage going to be made in the community. And I think those damage can be absorbed and, those damage or maybe some force, some event, reaction, response can be adapted, in a way to, better system to transform to, better system. So in a way, that the resilience is to the, that more, foundation to make those changes around. And then when we are thinking about the, the resilience and the health, care system, we did some study surrounding using a scorecard. So when we're looking at this scorecard, what we think healthcare system resilience is a kind of a framework. It's set it up. So it's more sharing that elements of the the healthcare system to what is, the factors to make this system, resilient. So it's more reflective, collaborative evaluation system in a way. The presentation, what I'm going to do is bit more, the other way around, rather than, I think, fit into the, of course, we have some, that we think this would be the, better model for the system. But I think as well as like we set up some framework, as well as, on the other hand, we have to see what is the societal changes and then also disasters. Some of them are usually disasters unexpectedly happens. So in a way, flexibility of the event to the system to adjust and then change so that my presentation is going to be a little bit more seeing the societal changes and what is the situation now and how this situation, in the future to be changed. And I think it's important to share the background to why we have to think to integrating a resilience healthcare system. So I share with some background in what's happening in Japanese context. So societal changes, as I explained, aging workforce and the population. So we, the population over 65 in Japan is growing very much. And another thing I think I'd like to mention is because disaster time and the non-disaster time, how we respond is pretty much, really connecting what the non-disaster time to reflect on what we can do in the disaster time. So one good thing is a universal health coverage that we have since 1961. So pretty much access to healthcare is good in condition in Japan. Accessibility is good. But on the other hand, aging population increment as well as, the care needs for those, that the aging population is becoming, has been great pressure on the care system. So we have long care insurance, and this is yes implemented early 90s, and all ongoing healthcare system alteration, as well as how we can keep people healthier in the community is another that aspect to think along with when disaster happens. Also, we have regional disparities. So between urban versus rural, healthcare access is quite becoming, the gaps. So of course, I think that this happens probably that some countries, especially between I think same developing country, developed countries, so called. So when we see in different regions in Japan, more people, younger, or more people who are, looking for the work, it's coming to the urban area, so that those accessibility and the availability of doctors and nurses in different areas are quite different. And another background, I think it's common, I think Asian, the Pacific region, we are exposed to the lot of hazard. So we had a big earthquake and also volcano landslides, and also that, of course, COVID-19. So if we're looking at some exposure of the hazard, so these are some maps. We are expecting along the Pacific Ocean, there's a trough. So we are expecting the big earthquake would happen in the next 30 years. So it's more high likeliness of the earthquake. And also looking at the population, I was talking about population, the increment. So we are around here. So compared to some half century ago, of course, those pink 65 plus age population is more becoming more, occupied within the whole population. And the right-hand side, this shows how since the 1995, so 30 years ago on top, and right-hand side is about 30 years later. So of course, those 65 years old population occupying 35% of the regions. So we have 47, the areas in Japan. So nearly whole of the area is becoming more and more, having a more aging population. So that's the current situation now. And let's see some little bit more localized. I'm living in the Hiroshima now, but comparing the area, so one prefecture, as a population, we facing nationally decreasing population size. But when you see the as previous diagram, aging population is increasing. Particularly, I think more than 75 years old people population is constantly increasing. So what does it mean? That the implication is more healthcare cost and workforce burden. So we have a system of providing home community-based care depending on the requirement of the person. So if you see that this is the color indicates the different care needs, and the red color is the most highest, that the more dependency of care. So most care needs, but I think important significance is between not slightly increasing who need a really care, but also I think significance is between the some care, but need a independent, but rather than becoming independent, but need a little bit requiring care population is getting more and more. So in the middle level of care is more, increasing. So that could be, if you're thinking about chronic illness management, maybe some people has, that mobilization restriction, maybe need some wheelchair or, some walking device to support them. So thinking about that, how do you support them when they need to evacuate, or how do they support them if they're in the evacuation center setting? So all those consequences is quite needed to tailored, and then we have to consider at this moment. So I explained all the current societal situation and the forthcoming expected future. So what could we do? So I will share some progress, but looking back, what sort of measurement has been progressed. So I have 4 points here. So first thing I'd like to share with you is how disaster preparedness and response has been changed. So of course it's only a half an hour presentation. I cannot go in deep. So it's a very generic, but I'd like you to grasp the some, I guess, progress overview what happened in Japan. So since the 1995 earthquake, so there are many deaths occurred, could be saved and avoidable deaths. So based on that experience, DMAT, Disaster Medical Assistant Team. So I think a lot of country has those medical, assistant team now. So officially established 2005 with the Ministry of Health, and the training has commenced. And this, that DMAT development has been developed, and capacity building. So sorry, it's a bit jumped up here, but in 2022, so altogether there are 2040 DMAT teams all over Japan. So, thinking about the last 2 decades, that, the capacity building has been accumulated and then has been continued. And between the time, I think a lot of experience, exposure to disasters, for example, 2011, and there are many different regions had earthquake experience, as well as a flooding, and including COVID, infectious disease as a part of the disaster. Those experienced, made, those area to run. So for example, DPAT, Disaster Psychiatric Assistance Team, was based on the experience from the 2011 disaster. So which tsunami, as well earthquake, as well as nuclear plant explosion, so that people lost their hometown to evacuate the not contaminated area. So as well as I think that DPAC, looking at the more psychiatric, the mental health area, a lot of hospital washed away, the psychiatry hospital, and there were needs to support them to evacuate and then continuing care to be provided. So that's learning was pushed to start the DPAT system too. So of course, disaster impact in the different area of, the whole community, but we won't have, different population focused or, the illness. And so we don't want to break down once the service support provided. So that there are many different, the disaster assistant team was formed. For example, we call the DWAT, Disaster Welfare Assistance Team, which is more focusing on the more who need maybe mental health support or people with disability. And PCAT is newly formed, so this is part of the primary care assistant team. So there are many the teams now, which has a strengths. Each team has their own strengths to fit into the disaster according to the different phase. So I think it's more diverse to support the disaster through the disaster phase. So that is a current situation in Japan in terms of the disaster healthcare assistant team. And of course, those differences making is have to go along with the, I think, national medical planning. And of course, there is a, each country has a different planning, national medical planning, health planning. So, of course, this disaster medicine healthcare team forming has to be go with the national planning. And at this moment, the eighth national medical planning is ongoing. And it's more about how gap is more filling out the non-disaster time and disaster time. So how we could prepare better during the non-disaster time by implementing a business continuity planning. And then also, I think, because we are expecting a huge earthquake in the next some years, so not only the one regional, impact, but the huge area impact, how we could cope with if we have a huge area impact. So, multiple coordination, multiple, communication. So I think this is a next step to thinking about how we can cope with the large scale of disasters. And the second point is the workforce and the collaboration. So as explained that there are many different type of disaster assistant teams has been formed and developed. So that means like we have to sustain those training and to be, to members to credential. We don't want them to go to the affected area without knowledge or skill. So capacity building is a very important part of it. And I can share some from a nursing perspective. So we have a disaster volunteer nurse registration. So we train them locally through the nursing association, and they deployed as a volunteer nurse. And coordination, of course, is important. So this is becoming a part of deployment coordination with the Ministry of Health, and I think it has been changing the how they coordinate. It's because of more larger scale of health disasters. In the case, how we can coordinate between local, prefectural, regional to the national body. So that has been changing, and then I think that gradually there's alteration has been made. Now, of course, volunteers and the NGO cooperation coordination is going on. And then one thing I'd like to mention is policy and governance. I think governance is becoming more larger focus, I think emphasis in progress. And of course, as I mentioned, that along with the national health policy, for example, in Japan, we have a healthcare vision 2035, and then Health Japan 21 national policy. And I think that's looking at what is a national, that the healthcare policy is heading to, and how we can fit in or go along with those health policies quite important as well. And then also that we have a community-based integrated care system. So the focus was quite, more elderly people before, but these days more comprehensively from birth to the, elderly. So from baby to, elderly people. So becoming more inclusive healthcare system. So I think we have to think about those systems too, as I said, along with the disaster healthcare system too. And fourth is digitalization and innovation. So I think in the disaster deployment system or coordination system, so it's becoming more digitalized and as a tool, part of the tool, and then management of the workforce or surveillance of the affected people becoming more the focused, and I think it's really great to oversee the changes, and also you can see the different disaster between disasters and then another disasters. So there are 4 points that the progress. If I share the details, it's becoming huge. So if you have any questions, we can share, discuss later. And within the 4 points, I'd like to just share I get kind of an update what is happening in Japan. So I think, as I said, strengthening the governance is becoming more, emphasized, focused. So new Prime Minister, I think that the planning to do a disaster prevention agency. So in 2026 planned. So what this is doing, I believe that some country has those agency, disaster risk reduction agency oversee, but I think depending on where that agency is located. So in Japan context, what currently it is within the cabinet office. So I think by putting level, scale up as an agency, having more staff there, and also, the cooperation among industry, government, academia, and the public. So involvement of those, the players is more, open. And I think because of local government, if you looking the local context, because of the the workforce shortage, who knows the disaster risk reduction and then involved in those community planning. in a way, it's really constrained. So I think it's having more, support from the, national levels to cooperate with the local level is a more, the important from now on. So that's the planning. And there are some, that the purpose, I think that, or maybe aims, benefit by setting up those agency is, overseeing disaster prevention as a whole, and all resources can be coordinated, collaborated. So that's the one thing. And also that, that what ultimate goal is protecting lives and the livelihood of the people. So I didn't put all the, the ministry and agencies here, but I think the idea is that whole, coordinating, collaborating with all the different, agency ministries overseeing as a disaster prevention agencies idea. So, so these are the some functions of the agency, and yes, I think it's a little bit repetitive, but I think policies and national agencies relating disaster prevention can be more that holistically from the local to national level to be shared or communication will be promoted. And this relates to the second, function. And also that I think it's, that the response speed and the collaboration, often that the local capacity may be a little bit, maybe limited due to those, that the current situations, as, as I explained at the beginning, so that I guess collaboration and, with more national level is more expected, I think. So those three functions are the, that aiming by the agency. So I think this is the last slide. And by saying through this presentation, I'm not really a specialist in this area, but looking up through the, the readings and thinking about what's happening in Japan, I think, in my opinion, what is happening is, coordination and the communication is more than before becoming critical because of, it should be due to the probably IT and all those digital devices development, like local coordination can be amplified, from the local to another local to becoming a more, that combined communities and coordination depending on the size of the disaster and the original size of the affected area. So all those coordination becoming more complicated and also that complex. But I think, those coordination can be supported, promoted by digitalization and then maybe system adaptation and the changes. And because of those, that coordination, multiply another coordination means different sectors collaboration, maybe interprofessional and cross-sector collaboration is becoming more, that multiplied. And also, I think non-disaster time and disaster time communication, because of we're not ongoing non-disaster time preparedness, non-disaster time healthcare system. I think that is more, that of course important to think about in the case of disaster. But by looking back, being resilient, I think the non-disaster time healthcare system is quite, of course, important. So ultimately, phaseless application is probably most resilient, I think. And strengthening rural health care access and the technology equity. So I think, this is coming back to the non-disaster time, how we can, reduce the inequality between the rural healthcare and the urban access. And probably another aspect is the integration of climate change into healthcare resilience. So I think we have to think ongoing. And then thinking back, summarizing and reflecting on those, what is happening in the healthcare system, as well as disaster response assistant system over time. Of course, it has been changed. And also ongoing adaptation, what is happening now, and based on what we have to change is essential. So overall, resilience is a process, and it's not destination. So ongoing change, we adapt to the change to better system. Okay, so I think that's all for myself. And then I think if we have any question, we can go. I'm happy to discuss and answer. Okay. So stop the sharing for now. And so I'm answering that, yes, questions. So we'll just... So it's about the disaster prevention agency. Okay, so this is a more function, how it communicated with the, how Prime Minister or just praise, because yes, I think this is still ongoing. How I guess that the communication chain of the the communication will be how it take, right? So it is still that the last month I think there was an announcement how this is a function look like. I think it's still how the authorities decision making is on progress. So I'm not sure at this moment. So if you in the audience, if you know the publicly being announced, if you can share. So at this moment, I'm not sure how it command of the decision making is working. Yeah. Thank you.
Mayumi, Andrew here.
Yeah.
The Disaster Prevention Agency, which was the question one of the participants in the remote audience asked about. In the presentation, you indicated that it was launching in 2026, next year. Is there a firm date when that's going to take place, or is that still ongoing?
Yeah, I think still ongoing. I think it's all the what do you call the all those committees member discussing about how they're going to establish the agency. So still ongoing process, I would say. Thank you. Okay, so I think Paul, please.
Yeah, thank you, Mayumi. I'm sorry I can't do the Q&A because it doesn't work at my end, so I have to speak to you. Great presentation. Really always good to hear what you have to say about these things. One of the issues that is driving us at the moment is the cascading consequences of these disaster events that we haven't had to deal with previously. And the one I'm interested in is the problem of mis and disinformation during disasters, and interested to hear if you have any experience in Japan of misinformation during the events and how you have responded to that in the health system. Thanks, Mayumi.
Yeah, thank you for your question. Yes, I think misinformation happens everywhere. So maybe that the person who are in the deployed and maybe more experience more in one hand. But especially, that the safety or misinformation targeting, especially because affected people, older people, and who are maybe, that less, those people are vulnerable because they wouldn't have, access to, or maybe hard to, cognitively hard to decide, is this legitimate information? So always I think, that the government or maybe locally involved in the local government or who are, that in person directly looking after those people are informed and, what sort of, for example, like even the scamming of the, financially, and then I think taking advantage of this, like safety, rather than misinformation. I think it's a little bit different perspective, but there are a lot of, that targeting people who are trying to sneak into those situations to take advantage from the affected people. So it may be a little bit different answer, but we hear, or maybe we are more aware of that kind of safety, financially, physically, I think, information.
Mayumi, Andrew here. We have a question that came through the chat from Patricia Frost. And Patricia asks, what is the typical configuration of a DMAT team in Japan, one of the disaster medical assistance teams? Like the number of people
foundation,
team, and there's also a question about how the DMAT teams are funded.
So DMAT team is that once that there is a prefecture, that we have 47 prefectures, and they will, that the head of the prefecture decide whether they need support from, those DMAT and so on. So what they call reimbursement would be coming through the prefecture, so that the local government, that will be, that the source will be usually reimbursed. So there's a set of the, I think, criteria, so to be filled out, and once that they have to be recognized by the head of the prefecture to be, deployed. So you cannot say I'm DMAT and then just go. So that the kind of communication order. So I hope that is yes, I hope that answered the question.
And how many people are typically in a disaster medical assistance team?
Right, yeah. So typically, one doctor, 2 nurses, and I think 1 pharmacist and 1 logistics. So yes, I think 5, 6 staff as a one team. Yeah.
If anyone else has questions they want to send in through the Q&A, or you can, we're also monitoring the chat here. If not, we could wrap up a bit early. Do you have any closing thoughts, any takeaway messages for the remote audience, Mayumi, that you'd like to share? Well,
Okay, so yeah, I think there's one question.
oh, one
Yeah,
just came in. All
thank
right.
thank you for that. Yeah. Yes, you know that the scorecard, yes, officially, we didn't include the Japan, you know, that the residence scorecard, but I did one city, so it's an unofficial scoring. So wasn't we published the paper, but is not included part of the scorecard. So I think that it's really good to do, and for now, and then because we know that more about the collaboration between different agencies and then different you know, disciplines, like a multidisciplinary collaboration is important. So maybe it is a good time to do. Thank you for your questions.